Most people who notice their vision getting worse do one thing. They book an appointment, sit in a chair, read some letters off a chart, and walk out with a new prescription. That is it. That is the entire response to a progressive physiological problem. A stronger lens to compensate for a weaker eye. Nobody stops to ask whether the eye itself could be retrained. Nobody mentions that your eye is surrounded by muscles, real, trainable, atrophy-prone muscles, and that those muscles in most adults are operating at a fraction of their capacity. Nobody tells you that because a new pair of glasses generates revenue and a 3-minute daily exercise routine does not. I am going to tell you anyway. Subscribe to the channel right now and hit the like button. We are working toward 1,000 subscribers, and every single one matters. Here is what I want you to understand before we go any further. The system you trust with your health is not financially incentivized to make you well. It is incentivized to keep you returning. Every appointment, every updated prescription, every new frame fitting generates a billing code. Prevention does not. Self-care does not. What I am about to share does not require a copay, does not require a waiting room, and does not require anyone's permission. What it requires is about 3 to 5 minutes of your day and the willingness to treat your eyes the way you would treat any other part of your body that you actually care about maintaining. Let us begin with anatomy. Not the dead, memorized for an exam kind, but the kind that makes everything else make complete sense. Each of your eyes is controlled by 6 extraocular muscles. That term simply means muscles on the outside of the eyeball. These are the muscles that physically move the globe, that turn your eye left, right, up, down, and in rotation. The medial rectus draws your eye inward toward your nose. The lateral rectus pulls it outward. Together, these two handle all horizontal movement. The superior rectus lifts the eye upward and also rotates it slightly inward because of how it attaches. The inferior rectus pulls the eye downward with a complementary rotational component. The superior oblique and inferior oblique are primarily responsible for torsional movement, meaning rotational adjustments that keep your visual field stable when you tilt your head. All 6 fire in coordinated sequences every time you shift your gaze. Not one dominates. Not one can be removed from the system without degrading the whole. Now here is what most people, including a surprising number of clinicians, do not fully appreciate. These 6 extraocular muscles are not the only muscles governing your visual function. Inside the eye itself, you have the ciliary muscle. This is the muscle that physically reshapes your lens. The lens sits just behind your iris. When the ciliary muscle contracts, it releases tension on the fibers holding the lens, and the lens rounds up, increasing its optical power for near focus. When it relaxes, those fibers pull the lens flatter for distance focus. That constant dynamic adjustment is called accommodation. You also have the sphincter pupillae, which constricts the pupil in bright light, and the dilator pupillae, which opens it in dim conditions. Add it all up. A minimum of 8 muscles per eye, 16 for both eyes combined. 16 muscles that respond to training, that deteriorate from disuse, and that most people never deliberately exercise a single day in their lives. Sit with that number for a moment. 16. If you told someone you were going to get fit, but only intended to exercise 2 of the 16 major muscle groups in your body, they would look at you like you had lost your mind. But that is effectively what happens with the eyes. Modern life demands near constant close-distance focus. Screens, phones, books, dashboards. It almost never demands the full range of extraocular movement. The muscles responsible for peripheral gaze, rotational tracking, and rapid long-distance focus shifts spend most of their working lives nearly idle. Before I give you the 3 exercises, I want to address something I hear constantly in advertising, and it irritates me every single time. The claim is always some version of, do this one move and your vision improves dramatically. I want you to understand why that is physiologically absurd. Imagine being told that if you train only your index finger, you will become a concert pianist. A piano demands 10 fingers in precise coordination. Your visual system demands 16 muscles doing the same. One exercise targeting one movement plane cannot produce comprehensive visual improvement. What produces results is a systematic, complete, multiplanar approach. One that addresses the extraocular muscles, the internal focusing muscle, and the supporting tissue around the eye. No miracles, just physiology applied correctly. The first exercise is one I call the wipers. Early in my career, I spent time at considerable altitude, somewhere in the range of 13 to 16,000 feet above sea level. I was young, overconfident, and I did not wear UV protective sunglasses. That was a real clinical mistake, and I paid for it. Most people do not know that ultraviolet radiation does not stay constant as you gain elevation. It increases substantially. Above roughly 8,000 feet, UV exposure is sufficient to cause photochemical damage to the retina, the thin neurosensory layer at the back of the eye that converts light into electrical signals your brain reads as vision. I came down from that expedition and noticed a real, measurable deterioration in my vision. Not catastrophic, but undeniable. Rather than simply accepting a new prescription, I started experimenting. The wipers exercise was one of the interventions that produced the most rapid, noticeable improvement, and it has remained a cornerstone of my clinical recommendations ever since. Here is exactly how you perform it. Without moving your head, look as far as possible to the right. Maximum lateral gaze. Take your eye to the absolute edge of its range. Now, maintaining that extreme position, begin sweeping your gaze slowly in a wide horizontal arc from the far right all the way to the far left, then back again. The movement should be slow and deliberate. Not a quick flick, but a controlled, smooth sweep along the outer boundary of your peripheral vision. Maximum amplitude both directions. You should feel a distinct pulling or stretching sensation in the muscles on the side opposite to the direction you are moving toward. I named this the wipers because of a precise functional parallel. The way windshield wipers clear rain from the glass and restore a clean, sharp view of the road ahead. That is exactly what this exercise does for the visual field. It clears the blur. It restores clarity, and most people perceive the effect within 1 or 2 repetitions. When patients perform this for the first time, the most common reaction is discomfort, sometimes actual pain, at the far lateral position. This does not signal injury. It signals a lifestyle diagnosis. Think about how your eyes actually move during a typical day. You look at your phone. You look at a screen. Occasionally, you glance at someone across the room. Your extraocular muscles operate in a very narrow range. Research suggests that for most modern adults, the functional range used in daily activity represents roughly 10 to 15% of the full available arc of motion. Day after day, the muscles operating outside that narrow range receive almost no demand. Like any muscle subjected to chronic underuse, they shorten, stiffen, and lose elasticity. Connective tissue tightens around them. When you then drive your eye to the far edge of its range, the muscle on the opposite side pulls against that stiffness, and you feel it. Here is why this matters beyond comfort. Chronically tight extraocular muscles exert mechanical pressure on the eyeball itself. The eye is not a completely rigid structure. It responds to external pressure. When the surrounding muscles are in chronic contraction, they compress the globe. That compression affects the microvasculature, the small blood vessels supplying the retina. The retina is neural tissue. It is an extension of your brain located inside your eye. Neural tissue is among the most metabolically demanding tissue in the body, and it is exquisitely sensitive to reductions in blood supply. When retinal perfusion is compromised, even modestly, visual acuity declines. So when you perform the wipers with maximum amplitude and feel that stretch, you are actively reducing mechanical compression on the eyeball, restoring vascular flow to the retina, and improving the oxygen supply to the tissue responsible for your vision. If you commit to this exercise daily, here is the typical timeline. In the first week, the discomfort at the extremes of gaze decreases noticeably. By the end of 2 to 3 weeks, it is largely or completely gone. That disappearance is a reliable clinical indicator. It tells you the extraocular muscles have regained a healthy resting tone. They are no longer chronically shortened. Maintaining that baseline requires only a few minutes of daily practice. The second exercise is vibrational massage of the eyeball. In manual therapy, there are 4 fundamental intervention types. Effleurage, which is smooth gliding surface contact. Friction, which is deeper localized rubbing pressure. Kneading, which is compression and rhythmic release. And vibration. Of these 4, vibration is uniquely capable of transmitting mechanical energy deep into tissue. It travels as a propagating wave, moving through the full thickness of whatever structure it contacts, including layers that cannot be reached by surface pressure. This is well established in manual therapy literature and is exactly why vibration is used when the target tissue is deep. Apply that principle to the eye. Inside the eyeball, you have the vitreous humor, a gel-like substance filling most of the interior volume. You have the three concentric wall layers, the sclera on the outside, the choroid in the middle, which is densely vascular, and the retina on the inside. All of these structures are surrounded by extraocular muscles and orbital fat, wrapped in a fibrous capsule called tenons fascia. To produce a beneficial effect on all of these structures simultaneously, surface pressure is not the right tool. Direct, forceful pressure on the eye is contraindicated. It can transiently elevate intraocular pressure, which in susceptible individuals can be hazardous. Gentle vibration, however, is physiologically appropriate. It stimulates microcirculation, promotes tissue fluid exchange, and mobilizes surrounding connective tissue without generating harmful pressure spikes. Here is the precise technique. Place one finger at the inner corner of your eye, the medial canthus, where the eyelids meet near your nose. There is solid bony support from the nasal bone immediately underneath. Place a second finger at the outer corner, the lateral canthus, where you have the lateral orbital rim as support. Both fingers should rest primarily on the bony orbital margin, not soft tissue. This prevents inadvertent pressure on the globe. Now, with the soft pad of your fingertips, make the lightest possible contact with your closed eyelid. Not a press, a touch. The weight of the fingers barely landing. Initiate a fine, rapid vibration. Small amplitude, fast frequency. Continue for 20 to 40 seconds without increasing pressure. Then slowly lift your fingers away, pause for 5 seconds, and open your eyes. Most people immediately notice improved clarity. Colors appear slightly more vivid. Detail sharpens. This is improved microcirculation in the choroidal vessels, relaxation of the orbital musculature, and normalization of fluid dynamics within the ocular tissues, all in under a minute. Over 15 years in practice, I have encountered a handful of patients over the age of 70 who wore no corrective lenses whatsoever. Not reading glasses, not distance glasses, nothing. Clear, functional vision in their 8th decade. That is genuinely uncommon. Age-related changes to the lens, retina, and ciliary muscle are documented and nearly universal in Western populations. So what distinguished these individuals? Without exception, they all reported doing some form of eye exercises daily, consistently, for years, treated as a non-negotiable routine in the same category as dental hygiene. They were also cognitively sharp, mentally alert, quick in conversation, clear in their recollections. The physiological basis for a connection between visual exercise and cognitive function is real. The visual cortex occupies approximately 30% of the total cortical surface area. It is the single largest sensory processing region in the human brain. Regular, complex visual training generates sustained neural activity in that cortex. The association between consistent eye training and preserved mental sharpness is something I have observed repeatedly enough that I no longer consider it coincidental. The third exercise targets the ciliary muscle directly. This is most relevant to presbyopia, the clinical term for age-related near vision loss. Presbyopia is what happens when, typically in the early to mid-40s, people begin holding reading material farther from their face to bring it into focus. It affects virtually everyone in Western populations who lives long enough and is almost universally managed by prescription of reading glasses or progressive lenses. The standard explanation is that the lens hardens with age and loses flexibility. This is partially accurate, but here is what rarely gets mentioned. The ciliary muscle in the presbyopic eye retains its contractile ability. Research has demonstrated that even in presbyopic patients, the ciliary muscle continues to contract in response to accommodative effort. It is the lens that fails to respond, not the muscle that fails to fire. This means the ciliary muscle can still be trained and may slow the functional decline of accommodation when exercised consistently from early enough. The standard recommendation is the near-far focus shift. Hold your finger close until it blurs, then pull it back to clarity. Repeat. This works, but it loads the ciliary muscle in a single plane. I have developed a more effective version. Bring your finger toward your face until the image begins to soften. Hold it at that distance. Now, rather than moving it straight toward you and away, begin moving it in a slow circle, upward to one side, downward to the opposite side. Maintain the clearest focus you can manage throughout. The ciliary muscle must now work not only to maintain near focus, but to adapt dynamically as the target shifts in space. Then reverse the direction. Then incorporate distance changes during the circular motion, gradually bringing the finger closer through one part of the arc, drawing it back out through another. This produces a multiplanar, dynamically varying load on the ciliary muscle, a training stimulus categorically more effective than simple linear movement. The practical challenge with any eye exercise program is not learning the technique. It is maintaining the habit. The solution is anchor linking, attaching the new habit to an existing, automatic daily behavior. I do my ciliary muscle exercise in the elevator every single time. I press the button, use the overhead light as my visual target, and for 30 to 40 seconds run through the circular accommodation drill. No extra time, no willpower required. The elevator ride is the trigger. Your anchor might be different. The first 2 minutes of morning coffee, the 60 seconds while your computer boots, moments at a traffic light. It does not matter what the anchor is as long as it is daily and reliable. 3 minutes done consistently every day for 6 months far exceeds a 45-minute session done once a week. Consistency is the entire game. Exercise is a biological stimulus. The response to that stimulus depends entirely on the quality of raw materials your body has available. Exercising muscles sustained by a nutritionally depleted system produces a fraction of the possible result. Progressive myopia is almost universally accompanied by specific nutritional deficiencies. The most important and most commonly deficient in northern latitude populations is vitamin D. Its relationship to retinal health is documented. It plays a direct role in the function of photoreceptors, the specialized cells that detect light. Its relationship to macular degeneration risk is well established in epidemiological research. Age-related macular degeneration is the leading cause of irreversible central vision loss in adults over 50. If you are doing eye exercises but your vitamin D level is deficient, you are working against yourself. Get your level tested. If you are deficient, correct it. Supplementation is inexpensive, safe within appropriate dosing ranges, and has meaningful positive impact on immune function, bone density, cardiovascular health, and mood regulation alongside your eyes. The ciliary muscle begins showing functional decline in the late 30s. By the mid-40s, most people notice it clinically. By 50, macular degeneration risk factors rise considerably. After 60, uncorrected vitamin D deficiency compounds retinal aging at an accelerating rate. The answer to when should I start is always the same. Now, write your age in the comments. That information determines which exercise is most urgent for you right now and helps me build content relevant to where you actually are. If your vision is declining, examine what you are doing to your liver. The liver's functional state has a meaningful impact on the metabolic environment in which your eyes sustain themselves. Fried and smoked foods generate polycyclic aromatic hydrocarbons and oxidized lipid products, both hepatotoxic. The liver must neutralize these compounds at the expense of its other functions. Processed meats add nitrites, synthetic colorants, and preservatives that serve no nutritional function but must all be processed by the liver. The less adulterated your food, the less chemical burden on the organ performing the largest share of your body's detoxification work. Chronic anger compounds this. Sustained irritability drives systemic inflammation, impairs bile flow, and over time contributes to hepatocellular damage. This is not metaphor. It is biochemistry. Milk thistle, specifically its active compound silymarin, has among the strongest evidence bases of any botanical agent in hepatology. Silymarin stabilizes hepatocyte cell membranes, stimulates protein synthesis for cellular regeneration, and functions as a potent antioxidant. These mechanisms are pharmacologically documented. If you are serious about supporting the metabolic environment in which your eyes function, the liver is a legitimate target and milk thistle is a legitimate tool. Here is your complete protocol. Free exercises, 3 to 5 minutes per day. The wipers, full amplitude horizontal sweeps targeting the extraocular muscles, releasing chronic tension and restoring retinal blood flow. Vibrational massage, 20 to 40 seconds of gentle fingertip vibration on closed eyelids targeting deep orbital tissue and choroidal circulation. Circular accommodation training, Multiplanar ciliary muscle loading, producing a substantially more effective stimulus than standard linear near-far exercises. Attach each to a daily anchor. Reduce fried, smoked, and processed food. Consider Ciliary-based liver support. Test and correct your vitamin D. Take an honest look at whether chronic stress is contributing to your systemic inflammatory burden. I am Dr. Bennett, and I built this channel because 15 years of clinical practice taught me that the gap between what patients are told and what they could actually do for themselves is enormous. That gap exists because closing it is not profitable for anyone except the patient. Subscribe to the channel, leave a like, and help this channel reach 1,000 subscribers. Help me get there.